This lecture is on major connectors, minor connectors, and rest. It is part one of a two-part series. Upon completing this lecture, please review part two with the same name. Every removable partial denture is made up of the components listed above. Only one of the items above, the indirect retainer, is not necessarily present on all removable partials. The correct term when asked to name a component part is one of the terms listed above. For example, the term clasp or clasp assembly or I-bar is not the correct answer when asked about a component part. Getting the terminology correct is one of the objectives of these lectures in removable partial dentures. National board questions often test your understanding of the correct terminology. The components are major connector, minor connector, direct retainer, reciprocal component, rest, base and teeth, and on some partial dentures, the indirect retainer. The major connector is the component of the partial denture that connects the parts of the prosthesis located on one side of the arch with those on the opposite side. It is that unit to which all the other parts are directly or indirectly attached. It provides cross-arch stabilization to counteract displacement of the prosthesis by functional forces. All major connectors must be rigid. They must protect the soft and hard tissues from damage. They must provide a means of adding indirect retention when indicated, and must be able to have bases and teeth added to them. They should also promote patient comfort as much as possible and be designed relatively aesthetic if possible. The major connector must be rigid. Rigidity helps resist flexing and torquing of the framework. If it's not rigid, then forces would be transmitted to the abutment teeth and soft tissues. This in turn would cause destruction of the natural tissues. The major connector distributes forces to the abutment teeth, the bone, and the soft tissue. It does not allow for impingement of the free marginal gingiva by the major connector if the partial is designed well. It must avoid the marginal gingiva by a minimum of 6 millimeters if you dip down away from the teeth. It must cross the marginal gingiva at a right angle. If it were flexible, it may cause severe damage to the teeth and soft tissues. There are some rules about the location of major connectors. They are: we have to stay away from the movable tissue. In the first picture, the lower border of that major connector cannot go any lower than the functional floor of the mouth. It cannot inhibit movement of those movable tissues when the patient sticks out his tongue to wet his lips or lifts it to the palate. We also have to avoid the marginal gingival tissues. The superior border of the maxillary major connector must avoid the gingival tissues by a minimum of 6 millimeters to maintain periodontal health and to alleviate packing of food in those areas. The mandibular major connector has to avoid the marginal gingiva by a minimum of 3 millimeters. The borders of the major connectors run parallel to the gingival margin when the border dips down to avoid the teeth. We have to avoid bony and soft tissue prominences. When we have a dramatic bony torus present on the maxillary arch, we may try to avoid it with a different design that may not be as acceptable as desired for rigidity, but it's indicated when the structure is present. Relief is placed beneath the major connector in the areas of interference. When we have a less pronounced torus or a strong median palatal suture, we place a slight spacer in the area of that torus called relief when the framework is fabricated, to provide less pressure on the bony area under function. We also provide relief under the major connector on the mandibular extension base removable partial denture framework to prevent impingement of the tissues when the partial denture rotates. Remember that there's no tooth holding that partial denture up away from the tissues in the posterior. So we have to allow for that rotational movement, which allows the major connector to dig into those tender mandibular areas behind the incisors. It's covered by very thin tissue, so that relief helps to provide a slight space for rotation. There are some additional rules about placement of major connectors. The anterior border of the major connector should end on the posterior slopes of the rugae. On the picture at the top, notice the prominent projections of tissue in the anterior maxillary palate. These are rugae. The anterior border of that major connector sneaks up and ends on the posterior of that projection of tissue. It therefore becomes kind of confluent with the soft tissue and does not stand up as a bulk of material, as it would if it crossed that rugae and stopped at that point. Then the patient would feel this lump, and it would be very uncomfortable and disconcerting to them. We must also make the major connector as symmetrical as possible. Sometimes we have to place another rest and more major connector for this to take place, but the patient's neurological system likes symmetry. It should not cross the midline at an oblique direction. Notice how the posterior border of that major connector crosses perpendicular to the midline of the palate and then swings posteriorly when it reaches the inclining portion of the ridge. The posterior border of the posterior palatal strap must not extend past the posterior palatal seal, which you will learn about a little bit later in complete denture course. The major connector should extend from and scallop from embrasure or contact point to contact point in order to close any space for food impaction. It must also cover the cingulum, as shown in the lower right picture. The maxillary major connector has a raised area all along the borders of the major connector that prevents food from accumulating under the major connector. It is created by scraping a depression using a small spoon excavator into the refractory cast before the framework wax pattern is placed onto the cast. It's created approximately 0.5 to 1 millimeters in depth. It is called beading. The characteristics of a health-friendly major connector are: it's made of an alloy that's biocompatible. Some nickel-containing alloys may still be used by some laboratory technicians, and they should be avoided. This is especially true for the patient who indicates some type of an allergy to metals or to their jewelry. It should cover no more tissue than absolutely necessary. Patients don't want a lot of bulk of metal in their mouth. They like major connectors that have reduced bulk and coverage, but at the same time, we have to make sure that it's rigid and distributes the forces over a broad area. It does not interfere with the tongue if it's well designed or irritate it. It is compatible with the natural contours and does not impinge on the oral tissues. It does not trap food. We have to avoid making right angles when we dip down or when we place holes in the palates. This area would tend to trap food, so we want to round all of our angles. It gets its support from other component parts of the framework, like the rests, and it contributes to the support of the prosthesis via the rest. There are two types of commonly used mandibular major connectors: the lingual bar shown on the left and the lingual plate on the right. Two others are used on special occasions. The lingual bar is the most frequently used. It will be the mandibular major connector of choice unless one of the other major connectors offers a definite advantage. There are some rules for placement of the lingual bar major connector. The superior border of the lingual bar must be located a minimum of 3 to 4 millimeters below the marginal gingiva. One text indicates 3 and the other one indicates 4. The lingual bar should be placed as far inferiorly in the floor of the mouth as possible. The limiting factor is the height of the movable tissues in the floor of the mouth. A patient must be able to stick his tongue out and lick his upper lips, and also be able to touch the palate without impinging on the inferior border of the major connector. A minimum of 8 millimeters of space must exist between the marginal gingiva and the movable tissues of the floor of the mouth, or a lingual plate would be utilized. The superior-inferior width of the bar must be 4 to 5 millimeters, depending on the texture read, but the idea is the thinner the bar, the more bulk it has to have in order to give it the rigidity necessary to keep from distorting the framework. Let's look at the lingual bar major connector in detail. It is half pear-shaped, and it is formed by using reinforced 6-gauge half pear-shaped wax when forming the framework wax pattern. It should be tapered superiorly so that it makes a nice smooth transition to the lingual tissue and to the tongue. The bulk is at the inferior border where it is least noticeable, and the inferior border is well rounded for comfort with the floor of the mouth when it lifts upward. It cannot impinge upon the musculature of the floor of the mouth. When the blockout and relief is done on the master cast at the time of fabrication, the resulting refractory cast creates a slight space under the lingual bar, which is especially necessary when you have an extension base removable partial denture, as we show in these two illustrations. Note the cross sections half pear-shaped and well-rounded at the lower border of the bar so as not to irritate the floor of the mouth in function, even though it is supposed to be placed slightly above the floor of the mouth in function. The superior border blends into the soft tissue so that it does not draw the tongue's attention to it. The bar as a whole is placed as close to the floor of the mouth in function as possible so that it too is not noticeable to the tongue. If it's really high, the tongue is drawn to it, and a nervous person might find it quite distracting. A minimum of 8 millimeters exists between the floor of the mouth and the marginal gingiva, or if it doesn't exist, a lingual plate, sublingual bar, or cingulum bar should be used. We usually use the lingual plate as our next choice. That 8 millimeter number is derived from the fact that you have to avoid the marginal gingiva by 3 millimeters, and the bar itself has to be 5 millimeters in width. For the lingual bar, you should use it if a Kennedy Class 3 case exists, so long as you have enough room for the bar. It is very simple in design, and you have minimal contact with the natural teeth. Therefore, plaque control and tooth maintenance over time is better. There are some contraindications to the use of the lingual bar. If we have an interfering lingual tori, that would contraindicate it. There must be 8 millimeters of space above that torus, or we have to choose the lingual plate. If the partial denture is to have an extension base either on one side or both, where you get rotation of the framework around the fulcrum line during function, then the lingual tori will have to be removed before we proceed with the partial denture. A high frenum attachment on the lingual is also a contraindication. And if there is an interference with the elevation of the floor of the mouth during function, then we must use the lingual plate. There must be 8 millimeters of space between the floor of the mouth and the marginal gingiva in function in order to use our lingual bar. There are two ways to determine the height of the floor of the mouth in function. One is to measure the height of the floor of the mouth with a periodontal probe and the patient sticking his tongue to the vermilion border of his upper lip. You can then get a reading. If it's less than 8 millimeters, you'd have to use the lingual plate. If it's greater than 8 millimeters to the floor of the mouth, you can use the lingual bar. Another way is to take a custom impression tray and place it in the mouth and trim it until it is short of the floor of the mouth when the patient sticks his tongue to the vermilion border of his lip. Then use that tray for an impression and have the patient stick his tongue out during the impression. That way you capture the functional floor in the impression and, in turn, in the final poured-up cast. Another mandibular major connector is the sublingual bar major connector. It's not used that often, but it is used when the height of the floor of the mouth does not allow the superior border of the bar to be at least 3 to 4 millimeters below the marginal gingiva. It is placed inferior and posterior to the usual placement of the lingual bar, lying over and parallel to the anterior floor of the mouth. The sublingual bar major connector is used if the lingual frenum does not interfere or in the presence of an anterior lingual undercut that would require considerable blockout for a conventional bar. The lingual plate is a popular major connector that's used when we do not have enough room for the lingual bar. The upper border should be as thin as possible and follow the natural curvature and be above the cingulum. It must close the interproximal spaces in order to prevent food from getting into the spaces between the teeth. It extends from contact point to contact point in order to do this. This makes the upper border appear to be scalloped rather than flat across the anterior teeth. The superior edge of the lingual plate is knife edge so that it does not create ledges on the teeth, which would interfere with the tongue. It needs to be a smooth transition between the plate and teeth. The upper border should not be above the middle third of the lingual surface, except to cover those interproximal spaces from contact point to contact point. The lingual plate should be made as thin as possible. The inferior border is half pear-shaped and is formed with 6-gauge wound wax, and 2 layers of 24-gauge wax are used to complete the pattern incisally. Deep embrasures between the teeth must be blocked out parallel to the path of insertion, and relief is placed to create a slight space between the major connector from the marginal gingiva to the apical portion of the framework. The tissues below the major connector are thin and can be impinged upon, especially when the extension base partial denture rotates around the fulcrum line. The inferior border is placed as low in the floor of the mouth as possible without impingement upon the functional floor of the mouth. It's important to note that the lingual plate is not an indirect retainer. It does not have rest seats prepared on each of those teeth. There will be rest at each end of the major connector, but by definition, the indirect retainer must have a positive rest seat. The indications for use of the lingual plate major connector are: if you have a high frenum attachment and the space available is less than 8 millimeters, the lingual plate is indicated. In the class 1, where you have residual ridges that have undergone extreme resorption, the lingual plate helps stabilize that partial. If you want to stabilize periodontally involved teeth, you use the lingual plate major connector. And when you plan that in the future you're going to have loss of those anteriors, the lingual plate allows you to do some repair and add a tooth to the existing partial more easily than if you have the lingual bar. When a patient has spaces between their teeth, we must dip down or place a step down between teeth to avoid unsightly metal showing. The superior border of the plate must still cover the cingulum. The borders of the plate will extend toward the contact point and then turn downward at the line angle and go to the level of the gingiva. It then turns and approaches the adjacent tooth and turns upward at its line angle. One of the problems is that this step down may create a food trap, and you still need 4 to 5 millimeters of thickness in the thinnest part of the lingual bar. The bar is usually made thicker to give the necessary rigidity to the framework. It is still 1/2 pear shape at the floor of the mouth. Some of the advantages of the lingual plate are: it's very useful, obviously, when there's insufficient room for the lingual bar. It provides exceptional rigidity, yet does not interfere with the tongue. The patient usually has a pretty good acceptance of the lingual plate. It can act to help stabilize periodontally involved teeth, and you can add loops when a tooth is lost in that anterior area in order to repair the partial rather than having the patient have to have it remade. It can also be used in some cases where the lingual tori cannot be removed for some reason, like health reasons on the patient. There are some disadvantages to the lingual plate. And the amount of metal that's involved in the lingual plate may be a problem because it can cause decalcification of teeth under the plate, and oral hygiene becomes an issue. In some designs, we may plate the anteriors and then we choose to dip down away from some of the posterior teeth. If we do a step down or dip away, then we ought to dip at least 2 teeth widths before we come back up to plate the back of a tooth. That space will eliminate the possibility of trapping food if we use 2 teeth rather than just dipping down for 1 tooth. The only exception here is when we use an eye-bar concept, which we'll learn about later on. Another type of major connector not seen very often is the double lingual bar. It's sometimes called the Kennedy bar or the continuous bar. The lower component of that major connector is similar to our lingual bar. It has the same shape, which is half pear-shaped, and it avoids the marginal gingiva by a minimum of 3 to 4 millimeters. The upper component is half ovoid, and it's 2 to 3 millimeters in height and 2 millimeters thick. The upper border should be scalloped, and you will find rest at each end of this major connector to support that partial denture from moving in an apical direction. The advantages of the double lingual bar are, when there are rests present at each end of the major connector, then it extends indirect retention. It also contributes to the stabilization of the partial denture in a horizontal direction, and it allows free flow of saliva and marginal gingiva stimulation. The disadvantages of the double lingual bar are: 1, it's a major food trap. That small amount of space that exists and sometimes crowding of teeth make it a perfect target for trapping food. The second disadvantage is that for some patients it's very annoying to their tongue, and it doesn't meet with good patient acceptance on the whole. It really isn't a great choice as a major connector. A much better choice is to go ahead and use the lingual plate instead of this double bar. I rarely, if ever, have seen it in our clinics. The labial bar major connector is an unusual situation and not used too often, but it is located on the facial surfaces of the mandibular teeth, and the projections engage the undercuts. It is half pear-shaped like the lingual bar major connector, and it's usually longer than the lingual bar. The indications for the labial bar are when you have extreme lingual inclination of the remaining lower incisor teeth and the lower premolars, when you have a large inoperable lingual tori as shown on the patient on the right, or the patient can't have surgery for some reason. When you have severe and abrupt lingual tissue undercuts, it makes it impractical to use the lingual bar or plate and more practical to use the labial bar. It's really necessary in rare instances. You would like to do everything you can do to avoid having to use the labial bar by doing mouth preparations such as crowns or extracting malposed teeth and surgical removal of the tori. The swing lock is a variation of the labial bar. It has a labial or buccal bar that is connected to a conventional major connector like the lingual plate, in this case on the lower. It has a hinge on one end and a latch on the other. The prosthesis kind of opens like a gate in the anterior. Support is provided by many rests that are located on the remaining teeth, but retention is provided by I or T-bar type projections on the labial or the buccal. It can also be provided by base, as shown in the top picture on the left, when the bar would be very unaesthetic when completed. The indications for the swing lock are when you have a key abutment tooth missing. An example would be like where you have a canine and you have it ending with lateral incisors, you can still use this swing lock. When the tooth contours are unfavorable as in the case where you have severe labial inclination of those mandibular anterior teeth. Also, unfavorable soft tissue contours may exist, like undercuts. And when the teeth are questionable from a periodontal standpoint, by placing retention on all of the teeth with the little bars, it all shares in the load of the retention. So it doesn't usually destroy the partial when one of those teeth may be lost. And today, with implants being a regular mode of treatment, I don't think you see as many of these because people are adding implants to provide the retentive mechanism for partial or conventional partial. In regards to the swing lock, some of the contraindications would be if you have a patient with poor oral hygiene or lack of motivation. This is not the major connector because of its extreme amount of contact with the teeth. If you have a shallow buccal vestibule or labial vestibule, then that negates the use of the swing lock. If you have really long distal extension areas, then this major connector holds so rigidly up against the teeth that you may find you can get some tipping of the teeth to the lingual. And lastly, you need to look at the patient and what they show as far as aesthetics, because it may provide poor aesthetics with those bars coming up onto the anterior teeth if that person happens to be what I call a lower shower and displays a lot of mandibular teeth. Let's look at the maxillary major connectors. They are the palatal plate, single palatal bar, single palatal strap, U-shaped palatal connector, the anterior-posterior palatal bars, and a combination of anterior-posterior palatal strap type major connectors. As far as major connector rules, the major connector components resting on unprepared tooth surfaces or on inclines lead to orthodontic movement of the teeth and slippage of the prosthesis. Settling leads to destruction of the periodontium. The solution is that you need support for the major connector by positive rest seats. You need to bridge the gingiva with adequate relief or avoid the gingiva adequately to keep food from packing and to avoid cutting off the blood supply to the tissues, which leads to destruction. The palatal plate major connector is defined as a thin, broad palatal coverage covering 1/2 or more of the hard palate. It reproduces the anatomic contours, and you can kind of see the rugae present in the ones to the right. It also permits thermal conductivity of the metal so the patient feels cold and hot. The corrugation of the metal adds strength and allows for uniform thickness. It is in intimate contact with the tissues, and there is no relief placed on the cast before it is constructed. As far as placement of the palatal plate major connector, the anterior borders are placed a minimum of 6 millimeters away from the marginal gingiva, or it can cover the cingulums of all of the teeth, but it is never placed at the gingival margin, and you would like to avoid the speech zone if possible. It runs parallel to the mean curve of the free marginal gingiva. The picture does not show that type of rule. The posterior borders are extended to the junction of the hard and soft palate on an extension base RPD, or anterior to the vibrating line. You cannot get a posterior palatal seal in the palatal plate major connector. If you extend past the vibrating line, patients will complain of food and water getting up under the partial denture and possibly of dislodgement. Beading is placed on the tissue side of the palatal plate major connector along the anterior and posterior borders to aid in retention through adhesion and cohesion forces. Full palatal and cingulum coverage is recommended on the Kennedy Class 1 arch with just canine to canine left. The presence of plating over the cingulums of the incisors aid in indirect retention. The palatal plate can be used even with the first premolars present when the ridges are extremely resorbed. It can offer additional stabilization for the prosthesis. It may be used when the remaining teeth are also periodontally involved. It allows for distribution of forces over the entire palate. You need to have strong abutments, and direct retention must not be a problem with this palatal plate. You should have no interfering tori or strong median palatal suture when it is used, without slight relief placed over them. This is especially true when the ridges are very fibrous, as pressure may be exerted on these areas which have a thin, variable tissue covering. When some of the premolars are present and you have indirect retention on either the canine or the first premolar, the anterior border can dip away from the anteriors. It should be located as far posterior as possible to avoid interference with the tongue and the rugae area, so that the patient can make his S, CH, and J sounds without interference. The anterior border follows the contours behind the crest of the rugae, so that the border blends into the soft tissue of the rugae and makes the border less noticeable to the patient. The palatal strap is another maxillary major connector. It must be a minimum of 8 millimeters in width to be considered a strap. You will see it on unilateral and bilateral tooth-supported restorations, especially with short edentulous spans, like shown in the upper picture. The width of the palatal strap should be within the borders of the 4 supporting abutments and cross perpendicular to the midline. It is made rigid without bulk using a 22-gauge matte plastic pattern. It should be placed so that its borders do not interfere with the tongue. The anterior border of the strap in the lower picture could have actually dipped backward toward the posterior to avoid interference with the tongue. It should not be used to connect anterior edentulous areas with distal extension bases. And if it exceeds covering more than half the palate, then it becomes a palatal plate major connector. Another palatal major connector is the single palatal bar. A bar connector component must be less than 8 millimeters in width to be called a bar. The palatal bar is one of the most widely used, or should I say misused, and least logical of the maxillary major connectors. The major connector must have rigidity for cross-arch stabilization. Therefore, it needs a bulk. Bulk is uncomfortable to the patient. If it's too thin, it's too flexible and apt to be distorted when worn in the patient's favorite place, the pocket. The bar is half round in shape. It should be limited to short span Class 3 RPDs with 1 or 2 teeth missing on each side of the arch. It should not be placed anterior to the second premolar, as its bulk may interfere with speech and be irritating to the patient. Keep in mind that the definition of a strap is that it must be a minimum of 8 millimeters in width. The anterior strap should be located as far posterior as possible to avoid interference with the tongue and rugae area. The anterior border of the anterior strap falls on the posterior slope of the rugae. The posterior border of the anterior strap ends on the anterior slope of the rugae, if present, which avoids adding bulk by avoiding convex surfaces. The shape of the strap is uniformly thin and flat. The anterior strap is recommended to be 8 to 10 millimeters in width, and the posterior strap is a minimum of 8 millimeters in width. The anterior-posterior palatal strap is the major connector of choice for the Kennedy Class 1 and 2 RPD designs with extension bases. The posterior, being a strap, provides a wider distribution of forces when a bolus of food is masticated on the extension base area of the RPD. The posterior bar would sometimes be uncomfortable by digging into the tissues under the forces of mastication. The anterior-posterior palatal strap borders should cross the midline at a right angle. Patients don't like the major connector crossing obliquely across the palate. The width of the side connectors are usually 7 to 9 millimeters in width, with a minimum of width of about 7 millimeters. They are commonly used in the Kennedy Class 2 and Class 4 situations, but you will see it sometimes in the Kennedy Class 1 also. The posterior strap of the anterior-posterior palatal strap major connector should be flat and a minimum of 8 millimeters in width. It is located as far posteriorly as possible, but never on movable tissue. It would end just short of the vibrating line. The anterior-posterior palatal bar is a modification of the anterior-posterior palatal strap. The component that crosses the palate is a bar, so it's narrower than 8 millimeters in width, but it must be made thicker and bulkier. The posterior is a half ovoid in shape, similar to the palatal bar major connector. It's used when support's not really important, like in the Kennedy Class 3. It's used when the abutments are widely spaced apart, and they can be used to avoid a torus. It's frequently uncomfortable to the patient because of the bulk. It's not the first choice for the maxillary major connector and should be selected only when other options have been discarded. The last major connector is the U-shaped palatal connector. It's also called the horseshoe in our textbook. It is a band of metal that runs along the lingual of the teeth and must be a minimum in width of 7 to 9 millimeters. The medial border usually is placed at the junction of the horizontal and vertical slopes of the palate. Note the ones pictured to the right. The horseshoe or U-shaped major connector is used when there's a large inoperable torus on the maxillary arch, and when several anterior teeth are to be replaced on the Kennedy Class 3 or 4 designs. It is one of the most commonly misused major connectors. The objections to the use of the U-shaped major connector on the Kennedy Class 1 and Class 2 with extension bases is that it lacks rigidity and it allows flexure under occlusion. This transmits lateral forces to the abutment teeth and to the tissues. It can cause, because of its lack of good support, impingement on the tissues, which can cause damage. The other problem is that this is easily damaged as far as the person who wears the denture in his pocket. Also, the metal is often in the anterior, as in a Class 1 design shown on the bottom right, without an anterior edentulous area. This is the most annoying area to the tongue when this metal is present. In summary, the anterior-posterior palatal strap can be used with almost any Kennedy classification, but it's most frequently found with the Kennedy Class 2 and 4. The single-wide palatal strap is found with the Kennedy Class 3. The palatal plate is most often found with the Kennedy Class 1, and you might find an anterior-posterior palatal strap dropped in there somewhere. You want to avoid the U-shaped major connector when the Class 1 and 2 is the design, except when a palatal torus is present. Suggested readings for the materials covered in this lecture are listed below. There's a lot of good information in them that just doesn't fit into a few-minute lecture. You have just completed Major Connectors, Minor Connectors, and Rest, Part 1. Please proceed to Major Connectors, Minor Connectors, and Rest, Part 2. Don't forget to review Part 2 of Major and Minor Connectors. It covers the minor connectors and the rest, which we did